This is Dr. Jim Del Rosso, representing the American Acne and Rosacea Society, and we've heard quite a bit from Dr. Jim Leyden on the issue of Propionibacterium resistance, or less sensitivity to antibiotics, and the background on the research on P. acnes and Acne vulgaris. And in this part two, we're going to continue our conversation with Dr. Leyden, and I'm sure the information will be very helpful to the listeners. And we're going to have some dialogue on an area of acne where there really hasn't been a lot of attention paid. Most of the data we have is on treatment of facial acne vulgaris, but we're going to address the area of Truncal Acne Vulgaris. One of the things I want to open up with is our group did a study. We just basically surveyed different practices around the country to sequentially evaluate patients, in order, and see how many patients actually came in and mentioned when they had acne vulgaris, or if they had an overbearing parent, doing all the talking for them. What was the chief complaint? And whether it was face, whether it was just acne vulgaris, or whether it was face and chest or back, or, how often Truncal Acne Vulgaris was mentioned up front. And if it wasn't, the simple question is, where is your acne? How often did they say face versus face and trunk? And what we found is only about 3% of patients, this is about 700 patients around the country, only about 3% of patients had truncal acne without any facial acne at the time that they presented. About half the patients that had facial acne vulgaris also had truncal acne vulgaris, but only in 1 out of 4 cases, they didn't mention acne on their trunk, but most of them still wanted treatment for acne on their trunk. So our sense was that Truncal Acne Vulgaris is more common than maybe we find in clinical practice if we're not looking, and patients don't necessarily mention it because the focus is on the face. Now, taking that one step further, Jim, we looked at trying to compare the severity, just from a clinician standpoint. How severe is the acne on the face? How severe is it on the chest? And how severe it is on the back. And we really didn't find any consistency among the sites, and we even separated out chest and back. They could have more severe acne on the face, a little bit on the chest, and a range somewhere in the middle with severity on the back. So the severities didn't necessarily match up at any given point in time. And I was always thinking that Truncal Acne Vulgaris is harder to treat, it's more severe, and that's probably because of oral isotretinoin, those selected out cases that were more severe because of the type of acne they had. But looking across the board, I'm not so sure that Truncal Acne Vulgaris is always harder to treat as long as they can get medications applied to the area, which is obviously more difficult, or that the severities necessarily match up with facial acne vulgaris. So I really wanted to open it up with that and see what your impressions are of Truncal Acne Vulgaris, what information we have on managing it, maybe talking a little bit about benzoyl peroxide cleansers, which are obviously applicable to that area for different reasons, and what you find we have as far as scientific information on managing Truncal Acne Vulgaris. So I want to ask you, what's your sense in terms of the severity of Truncal Acne Vulgaris in patients as compared to facial acne vulgaris?
A lot of patients have acne some acne, and sometimes, surprisingly, a lot of acne on their chest or back, and they come in present with the complaint mainly towards the face for the obvious reasons. The face is so much more apparent. I always say, let me see your back and chest. I mean, I don't ask them whether they have acne. I've always looked. And you said about a half patients will have some acne. That's about right, I think, somewhere in that 40 to 50%. And sometimes there's a lot more on the back or trunk, chest, etc., than on the face, and the face is more important to them. And having been around in the pre-Accutane era, I could tell you that I agree that that acne will respond the way the face does. It's obviously more difficult to treat with topical agents. The chest you can do, but the back, depending on how limber you are, how loose jointed you are, can be more or less challenging. And it's the larger areas, so topical, the bottles, the jars don't go as far. The compliance or adherence is less, I think, although I don't know if that's been formally studied, because of these difficulties. So I don't think it's inherently more difficult to treat. I think your point that people who need systemic isotretinoin, and they often have very, very bad acne wherever it is, and some of those patients have really interestingly intense inflammatory acne on the trunk and chest, and in that subset, it's very bad acne everywhere. Is more difficult to treat. It's not just the trunk. The trunk is more likely, obviously, and seems to be a little more prone to scarring across the board, although plenty of people get scarring on their face. But I think it's the response depends on what kind of acne they have, whether it's their face or their trunk.
There's a type of scarring that you see sometimes on the arms and the back, those little small, flat, white macular scars.
Yeah.
That's a little bit different sometimes in the trunk. That's very annoying.
You can see them. So you do see them much more on the chest and back than you do on the face. But sometimes you see them on the face. I've had patients sent to me with quote unquote resistant comedonal acne who really had follicular scarring. And so I have my own ideas about what's may or may not be the reason why some follicles are involved and some aren't. But I don't know that the density of follicles makes any difference, because most of the follicles on the face aren't involved.
Now, in the benzoyl peroxide wars with different products over the years, a lot has been made out of the fact that higher concentrations don't necessarily, when talking about leave-on formulations, don't necessarily impart any greater clinical benefit. People are not forth with that. But in thinking about the difference between something that you're going to apply, wash, and then rinse off versus something that you leave on, my sense from looking at the limited information we have on truncal acne, when you're talking about a wash, first of all, it has to be able to release and deposit some benzoyl peroxide in a short contact time, but also that in that situation, concentration might make a difference because you're just looking at trying to get as much on there because you're going to be rinsing it off quickly. Can you comment on concentration?
Those are good points, good question. All of us, including myself, just sort of assumed that benzoyl peroxide washes have been studied on the face, microbiologically. I've done that, and anything, 4% and above, I've never seen one that really didn't work quite well microbiologically. And there have been some clinical studies, and it's been predominantly on the face, and I guess we've been willing to assume that that's probably true on the trunk, on the back, if you get it there. Until we had a couple of experiences with benzoyl peroxide washes, they don't work as well. In fact, they work very poorly on the
trunk.
Back. Yeah, it was very interesting.
I think you reported one recently. It was an 8%.
Yeah, and
you saw no reduction.
I think it was 8%. Yeah, and that was. I said, whoa, So we repeated that, and got the same result. So then you say, well, what the hell is that all about? Well, I think a couple of things. There's an issue of how much contact there is. This is one place where you can't totally supervise the use. There's that part of it, but when you see the same result in 20 people, you can't imagine that all 20 did it equally poorly. A big range of effect, then you could say that sounds or looks a lot like difference in application, adherence, etc. But when everybody has a non-effect, it's hard to imagine that all of them did it equally poorly.
Right.
So what else could it be? Well, one of the things about benzoyl peroxide is that it's a very insoluble substance. It's in suspension in just about every product we have, except for one company that has a solubilized form for leave-on on the face. So when you apply it in the shower or whatever, an area where you have a lot more sebum getting to the surface because you have a lot more follicles, likely explanation that makes sense, because, as I say, if it was adherence, you'd expect to see a variance in microbiologic response, not everybody having no response.
What about the ability to deposit and release? I mean, with my simple mind, I think about it with shampoos, for example. There are big differences when you utilize different shampoos, especially, let's say, a conditioner. How what's in there makes your hair feel after a short contact time and rinsing it out.
The reason for that
or with cleansers that we have that deposit lipid, there must be some differences in formulation that allow components to deposit
in
quickly.
those cases, in the case of the lipid and in the case of the conditioners adhere because of electrical properties, positively charged agents in the conditioner that adhere to the negatively charged hair. In the case of the lipids, either petrolatum or triglycerides that are in body cleansers, they resist the water rinsing because water is not very good influencing the removal of those. So that's why that is. Now, in the case of benzoyl peroxide in a wash, obviously the wash works quite well on the face. It just doesn't work well, or practically not at all, surprisingly, but reproducibly.
And that was a formulation that you were able to show was effective on the face.
Very effective, highly effective.
But not on the trunk.
Not on the trunk. It was a real surprise, and I thought. Then I started thinking about it. First of all, when you have a surprise, you say, "Well, can we repeat it?" Was it a technical issue? And when you repeat it and you get the same result, then you're forced to try and think of ways to understand.
If you always do what you always done, you always get what you always got. So
right.
You need to do something different. But my understanding with those formulations, there was one particular formulation that was in an emollient foam that could be looked at as using for a short contact. Left on, it had a 95 or 98% P. acnes reduction, but when it was rinsed off, it was significantly lower. It was like 75%. But then when you increase the concentration a lot higher with a short contact and washing it off, as long as they applied it and left it on for a couple of minutes.
And see, in that situation, we could supervise that.
Right.
That application was supervisable. A question that we have not yet had the chance to find out is if we just gave people something like a foam and said, go home, put it on for a period of time, and then rinse it off. We don't know how well they do that, So there is that one element that's not been controlled for yet. But I suspect what we would find is a variance.
You would find a variance, but I'm thinking in terms of trying to recommend to patients what to use.
This foam short contact seemed like a reasonable, compromise for.
But they had to leave it on dry before then going in there and rinsing it off, correct?
Right.
So there was a period of short contact while it was dry. It wasn't like they just put it on while the water was rinsing over them in the shower.
No, they had to put it on, I forget what it was, a minute or whatever it was.
Right. So potentially that could be true with some of the other agents that we have that were cleansers. If we can get people to do that for a minute or so, whatever, we may actually get a better effect.
that may be sufficient, or it may be that the foam is a better release of benzoyl. Who knows? I mean, it opens up a lot of questions.
I think that we recommend a lot of cleansers and they're out there, but how people use them have a lot to do with the benefit.
Yeah, it looks like using a cleanser in the shower doesn't work on your trunk.
Right. If you just go in there and just put it on and rinse it off.
But you might be able to put the cleanser on, for a minute or so before you go in, but we haven't done that experiment.
Right. Now, the study that you did with the 6% cleanser, where you looked at the reduction in P. acnes, and you had P. acnes that were pre-existent in terms of their resistance to erythromycin and doxycycline, minocycline, and I think tetracycline.
Right.
I remember it looked like the magnitude of P. acnes reduction you would get at 3 weeks with them using that every day on the face it took about 3 weeks with the cleanser for what it would take 1 week with a leave-on formulation.
That's about right. That's my recollection.
So it may take a little longer, but it can get the job done, including less sensitive strains. Okay. But we know that for the face. We don't know that for
we don't know about the trunk, right? Based on what we saw, it probably wouldn't work unless you had short contact before rinsing.
I think that's a really important message if we're really trying to get truncal acne better, at least with the limited information we have now. With all your work with topical retinoids, what about utilizing topical retinoids on the trunk for truncal acne? I don't remember seeing any studies specifically for truncal acne, but what kind of experiences have you had if you've done that? I would imagine you've done that in some cases.
Yeah, we've done it. It works if you do it. There should be, I don't know why we don't have yet a foam retinoid, because foams are easier to apply to large body surfaces. And I think that would, creams and gels, you can go through a tube in a week.
Do you think maybe the foam issue might be, sort of unscientific concern?
I think it's been lack of...
Because it's a retinoid with a pregnancy issue and...
I think it's just lack of interest. Somebody was asking me, not too long ago, if I knew anything about a tazarotene foam clinical trial and I said I didn't know anything about it, and they said, well, they had seen it on clinicaltrials.gov, so maybe since the patent is out on tazarotene, maybe we will have at least a tazarotene foam. I think the success of clindamycin in a foam was mainly for truncal acne.
Right. Even though the studies were done on the face, it was promoted.
Yeah, but that's what people used it for.
Right. Yeah, and that's how it was promoted. Yeah.
Yeah, and I think that it makes sense because it's a large body area and you can get a lot more on.
So if you have a patient that comes in that you're going to treat with this topical therapy for the face, and you're looking at the trunk, and, it bothers them, but you're sort of saying, do I really think I need to put this patient on an oral antibiotic? They're 14 years old or whatever. Or can you manage it with just topical therapy? Or would you automatically say it's the trunk, it's going to be too much of a hassle, we'll give them a benzoyl peroxide cleanser and utilize an oral antibiotic because it's the chest and the back? Or would you try a topical approach?
I would say all of the above. Okay. I guess it's a matter of sense. You get the sense that some patients are going to be more attentive than others. When I've done it without giving an oral drug, I've explained to the patient and or the parents that this is more difficult to treat because of geography more than anything else. If it isn't sufficient, then we'll have to talk about taking something by mouth.
Right. So maybe a couple of months of giving the topicals a trial or whatever, and then stepping up if you need to, because you do have more parents. They're questioning about oral antibiotic use. Especially when they're younger or when they're teenagers.
Taking oral antibiotics or any drug is not the greatest. I learned a lot from my daughter, my oldest child, when she had her acne. She told me one day she finally figured out how to remember to take her pills every day. And she said she put them by her alarm clock. So when she got up and when she went to bed, if she didn't take one, it was because she consciously said, I'm not doing it.
Right.
As opposed to, I'll do that later, and then you forget. Then she, would forget.
Well, one of the things I recommend to parents, because kids are always checking, texting to see if that girl or that guy texted them, and just send them a reminder.
Well, nowadays
sometimes it works, sometimes it doesn't. It may annoy some of them actually. So I think in summary, we have a lot more information we need on truncal acne, but from the standpoint of a clinician, if you're really trying to optimize the benefit, if you can get a patient to utilize especially a higher strength benzoyl peroxide cleanser and put it on for a contact time of hopefully a couple of minutes before they get wet and rinse it off. If you can get them to do that, that might help with the information, that we have. And then if you're going to try a topical retinoid, obviously you have to work with the size of the tube and the area of application. Would you have them automatically moisturize with a topical retinoid? Because is the trunk more sensitive or less sensitive in certain areas?
I think the trunk in general is less sensitive than the face. And I think the face, there are regions that are more sensitive than others. So lots and lots of, very high percentage of patients can tolerate retinoids without need of a moisturizer.
Right.
And I think I've heard the advice given of putting a moisturizer on first and then putting a retinoid on. Well, that's very effective because you basically cut the concentration in half. No matter what you put on first, you're basically halving the concentration of the potential irritant.
Well, so I don't know that we have any actual data. I know there was one study on the face with ceramide-based. It was a CeraVe cream and then tazarotene. They told the patients to separate it by 20 minutes, but who knows if they actually did. Didn't change the efficacy, but it reduced some of the signs of irritation.
Oh, I'm sure it did that, but the question, but it's a complicated thing, because right. If you're putting less retinoid on, because in some people you've put it on too close together, you'll get some less efficacy. But in a group, you won't get lack of efficacy. Right. But you sure will get less irritation.
Right. And once again, like you say, you're looking at means, and you're not necessarily.
Yeah, you're not looking at how many had. How many achieve what level of irritation or what level of efficacy?
Well, maybe we can expect using benzoyl peroxide cleanser, higher concentration, try to get some contact time if they can. A topical retinoid, you may not need to automatically moisturize with it. And then, if necessary, after a reasonable trial, then step up to an oral antibiotic. Or, use the oral antibiotic from the beginning. That's an individual.
I've done that plenty of times.
So have I.
If I just thought the extent of the back in trunk was too involved, not that they would be willing and maybe even would apply it, that they would be buying so many tubes of stuff.
Right, and that's true because a lot of times it's on the upper back, which they can reach. They can obviously get it to their chest, so that's another important consideration. Okay. Absolutely. What about the idea of, and then we'll end with this, you're treating a patient for facial acne, and they have minimal to no truncal acne. Maybe they have mild truncal acne. It's not really a major concern to them, or they have no truncal acne. You're putting them on a topical benzoyl peroxide antibiotic combination on their face, but then you're saying, hey, they need an oral antibiotic too, maybe a retinoid on their face, but their face is pretty bad. They need an oral antibiotic. Now they have that antibiotic, obviously they have the benzoyl peroxide on their face to lessen any resistance problems, but they have unopposed oral antibiotic in the follicles of their trunk.
I think they should be doing it on their trunk, the benzoyl peroxide,
Yeah, automatically. Just wash with the benzoyl peroxide on.
And now that I know that the wash doesn't work so well, they got to do it some kind of leave-on for short contact.
Right. So we may be selecting out less sensitive P. acne strains just because we're not having benzoyl peroxide counter the oral antibiotic on the trunk. Okay.
Yes.
That's something I think a lot of people haven't thought about. Well, yeah. Jim, I want to thank you again. Anyway, I want to thank you for your time, and I think this is an area where we definitely need more research, but I think what we brought forward is something that a lot of clinicians, if they can get patients to do it, they may see additional benefit on the trunk. Have a great day.
Thanks.